During that year, during the 30, Putnam from Boston, developed an animal model based on occlusion of cerebral veins and on dogs, and he found abnormalities quite similar to encephalitis or to multiple sclerosis. And his conclusion was that the venular obstruction is the essential immediate antecedent for the formation of typical sclerotic plaque. And this has been published. It was published in 1937. The topography of veins and plaque in the spinal cord was subsequently described also by Aaron and Alexander very well. And this picture illustrates how the emergence of a multiple sclerosis plaque is related to the vascular system, and more specifically to the venular system of the brain. I was reached by a communication of Franz Selling in 2002, and he emailed me because at that time, as a surgeon, I was interested in valvular reconstruction, also at the saphenofemoral junction, to try to find something conservative in disorders of the lower limb. And he very kindly also provided me with this beautiful topography of plaque in multiple sclerosis with special reference to cerebral plaque, written by Thurman and Fogg and published in Denmark in 1965. And this is a fantastic, really fantastic work of a neurologist who followed up his own patient along years, and at the death performed, this is an example, performed the autoptic study, but in a particular way, trying to have a preservation, careful preservation of the venous system, and finally concluded that probably the progression of the disease is countercurrent respect the normal flow observed in or expected in the brain venous system. In the 70s, there was the introduction of catheter venography or catheter angiography in the world, and a lot of the radiologists tried to explore the vessels that were never investigated. And it was amazing that in French, published on Acta Radiologica, a group with Abul Khair and other, Leorish and other radiologists find 98% of spastic paraplegias presenting 2 or 3 stenoses at catheter venography. Venography were found in the jugular vein, in the valgus vein, hemivalgus, renal vein, and they described this kind of association. We do not know nothing about the patients, and also they tried to operate this patient, but with poor results due to heavy complication, and so this story quit. In the 80s, there was fantastic observation in London due to Adams, who was a professor of histopathology in St. Thomas Hospital in London, and he found microbleeding and perivenous iron stores in 47% of his material, especially in patients who died for other causes with relative early onset of the disease, and also, very interesting, a marker of venous hypertension in about 25% of people, because he found the venulus encircled by fibrin calf. And he described this and considered this as a neglected part of multiple sclerosis pathology, because it's more addressed to the relationship between the venous wall and the plaque and the inflammation seen in the multiple sclerosis. In the 80s, there is also good work on behalf of Franz Schelling, who was yesterday awarded by the International Society for Neurovascular Disease. He also found skull radiography in MS demonstrating striking widenings of the main venous passageways, and he extensively investigated this, considering also reflux as an overlooked part of the disease, venous reflux, and also proposed venous hypertension as a possible trigger of the disease. In the 90s, at the beginning of the 90s, or between 90s and 2000, there was a fantastic improvement in MR venography, and so it was easy to demonstrate the venocentricity of the plaque. This is probably the first study demonstrating that there is in 98% of the MS plaque a vein in the central part of the plaque exactly splitting the MS lesion. So this is very interesting because all the inflammation and the infiltration of the inflammatory cells is just around the central vein. In 2002, I tried to move out of the skull. Probably it was the first research looking at multiple sclerosis, trying to investigate the circulation, the venous circulation out of the skull. And this is the first case of reflux that I found at the junction level of the jugular vein with no Valsalva and simple activation of the thoracic pump, inviting the patient to breathe. I did not have a right probe to explore the supraclavicular fossa. You may see in the B-mode image that there is a shadow due to the clavicle. And at that time, I was convinced that this reflux probably was due to an external compression by bone or something like this. And I asked to my patients, to my normal vascular patient, if they were capable to propose to someone, relative or friend suffering from MS, to have a duplex investigation. And I found about 50 initial patients, and in about 55% of these patients, initial patients, I found really venous flow abnormalities by investigating these patients. But at that time was completely not capable to create a protocol by investigating findings related, for example, to physiology or something like this, that were coherent with this kind of abnormalities that I found. Also, I explored in postmortem studies, and I found these are veins which you may easily see intraluminal defect like septum membrane in the jugular vein. So I began to understand that probably there was something different by simple external compression, because I found evidence of intraluminal defect. And look at this. This is very interesting. No, sorry. This is a big, this point you may see a big inferior thyroid vein, never seen in a patient with MS. This is a collateral circle, very enlarged. This is one of the more characteristic substitute circle, because from the jugular vein, blood may shunt into the superior thyroid vein, run along the thyroid gland, and re-enter into the chest through the inferior thyroid vein. So I was very, very impressed by these post-mortem studies, by my very pioneeristic duplex observation. And so, in a lectureship at the Royal Society of Medicine in 2006, I tried to propose a parallel in a very provocative way between MS and chronic venous disease of the legs. And this was mainly based on histology. You may see that there is extravasation of red blood cells here. This is MS, and this is in the chronic venous disorder of the leg. We found also fibrin calf that was considered from 1982 a marker of venous hypertension. It was published by Bruce and Burnham as a marker of venous hypertension in the vein of the leg. And also you may see very, very easily that both diseases present macrophages migrated through the blood-brain barrier or through the venular side of the microcirculation, and these macrophages taken up iron. So this, I consider these similarities and very, very, very interesting. And shortly after this, I had a fantastic email by Dr. Aki, and he showed immediately his fantastic SWI imaging of iron in MS, and from that moment we began to exchange by email. I sent him my histology of iron in MS around the plaques, and he replied me by beautiful MRI imaging. So we started for the development of an ACD quality protocol by using a combination of physiological measurement and trying to compare patients and controls. And this convinced my ethical committee that there are really abnormalities in the extracranial venous system in patients with MS, and giving me the permission to investigate the patient with invasive catheter venography and the possibility to use just simple venous angioplasty in case of evidence of stenosis. So we chose a conservative, very simple treatment because at that time there was no evidence at all of the role of this stenosis. This is one of the first cases that really give us all the element of Ccsvi, the stenosis, the hypoplasia, the collateral circulation, respect to normal control. This is the first Adigos case. It was operated on December 11, 2006 by Roberto Galeotti, who is the head of our interventional radiology department in Ferrara. And 2 days later, he operated the first case on the jugular vein. This is depicted. This really was the beginning of the history. In 2007, we had our ethical committee approval. We published the first seminal papers on Ccsvi, and this was a very important part that I recommend to everybody. The constitution of an interdisciplinary team is mandatory to have good results. So we found a neurologist, we have our interventional radiologist, our vascular surgeon, vascular technician. All these figures are really very, very important if you should consider to establish a program on Ccsvi. This is our team at work, and I was always very interested in understanding how many calories are necessary for the life of a neurologist, because was my first contact with this kind of colleague. But really, Dr. Salvi, you may see, is always in our picture. I didn't find a picture without food. Big lobster. This was Doppler examination, blinded, but with cakes and pizza and everything, every day and night of what we collaborated. So it was very fun. And this is the first case operated on during a relapse for right hemiparesis. This is the Magazzini proof that show the hemiparesis of this young patient. And 2 days after the PTA, the patient was completely stable without any steroid treatment. And this suggests us that certainly for the rapidity of, in an acute case, this is a very important concept. This is not a chronic case. This is a relapse. But also the rapidity of the recovery after the relapse following PTA convinced us that there was certainly a causal relationship between venous disorders and the complex puzzle of VMS. In 2008, I was kindly invited at a ground round lecture at the University of Buffalo with my friend Robert Zivadino. We have big discussion, you may imagine, if you should know him. Big discussion. And we have another one meeting during summer in Croatia. Was very easily to be reached by me. And in July, I reached him in Abbazia. It's a beautiful place, really, in Croatia. And we tried to project a common work that was CVI-MS and FT-MS studies, and was really a big effort, a fantastic experience together, because it was a transatlantic cooperation with patients coming both from Buffalo to Ferrara for procedure, and our patients that were checked by Robert in a very sophisticated way by MRI with new non-conventional also MRI measurements. So we really learned a lot of pathophysiology of Ccsvi thanks to this cooperation. This was the group of the Niagara Falls, and again was invited by Dr. Salvi in a beautiful restaurant, of course, in Bologna. So this was again food. In 2009, I presented the first cases in a very important congress for the vascular people, was Charing Cross in London, chaired by Professor Greenhalgh, and I met Dr. Dake, and really was fantastic, because few months later he performed the first procedure also in Stanford in the United States. So this was really fantastic. And few months later we had the first meeting of people interested, interdisciplinary people in Bologna again. It was the first Ccsvi meeting. And now this is a reality. The reality is all people that are figured and are interested in this topic. This is the first INSNVD Congress last year, and we have a second annual meeting today. But to me, the more fantastic thing is the poster outside. Poster outside is fantastic because 2 years later we have a lot of young investigators that are performing research in this field, very interesting findings, and this is fantastic because this is the life of science, to have young investigators, young researchers that are working on this interesting theory and hypothesis. I think that this is not the end, but it's the beginning, because This is a recent Google Scholar, and I found more than 6,000 citation on Ccsvi. Thank you very much for your attention.
Thank you, Paolo.